All right, let's get right into it. Today's deep dive, we're tackling a topic that's, is pretty crucial for any surgeon out there, especially those gearing up for those big exams.
Absolutely.
We're talking about human immunodeficiency virus,
HIV.
HIV in the surgical setting.
Yeah.
So no fluff, just the facts,
Yeah.
just the stuff you absolutely need to know.
Straight to the point.
Okay, so let's break it down. What exactly are we dealing with when we talk about HIV?
Well, HIV, it's a lentivirus, part of the retrovirus family, and it's the one that can lead to AIDS.
Acquired immunodeficiency syndrome.
Exactly. And the thing about this virus is it really messes with the body's defense system, the
Yeah.
immune system. It
Right.
goes after and destroys these cells called helper T cells. They're also known as CD4 cells. And without those, well, the body's left wide open to all sorts of infections.
Makes surgery a whole lot more
Complicated.
complicated, yeah. And, as surgeons, we're constantly dealing with bodily fluids. That's kind of the nature of the job.
It is. And that's where the risk comes in.
So let's talk about that risk.
Yeah.
Who's most likely to have HIV? What are those risk factors?
So the first group that comes to mind is anyone engaging in unprotected sex,
Makes sense.
particularly men who have sex with men. They're at a much higher risk.
Okay.
And then there's exposure to infected blood products, like through IV drug use.
Right.
It's a big threat. And historically, we have to remember hemophiliacs, especially before 1985, they faced huge risks because of all the contaminated blood transfusions back then.
But things have changed, right?
Drastically. That year, they brought in this really rigorous blood screening, and that's brought those transmission rates way down.
That's good to hear. What about other ways HIV can be transmitted?
Well, there's the risk for babies born to mothers who are HIV positive. They can contract the virus during pregnancy, childbirth, even breastfeeding.
Wow.
And then, geographically speaking, some areas just have a higher prevalence of HIV. Parts of Africa, Southeast Asia, for instance.
Right. So let's say, hypothetically, someone is exposed to HIV. How long before they actually test positive?
That's the seroconversion period. Think of it like a battle going on inside the body.
Okay.
You have this exposure, and then the immune system, it's fighting, right? Before any antibodies show up on a test. For most people, that seroconversion happens within 12 weeks, but it can vary.
So as surgeons, our main concern, obviously, is being exposed during surgery.
Right. Exactly. It's all about those bodily fluids. And for us, the most common routes of transmission are needle sticks, splashes, anything that gets on the mucous membranes.
Right. And what are the actual numbers? What are the chances of getting HIV from those kinds of exposures?
Well, blood transfusion, that's the highest risk. About 90%.
90%.
But thankfully, that's pretty rare these days.
Because of the...
The screening, yeah.
Yeah.
Then you have needle sharing, which unfortunately still happens. That's about a 0.67% transmission rate.
And what about needle sticks? The ones we're most likely to encounter in surgery.
Percutaneous needle sticks, it's estimated to be about 0.3%.
Still a risk.
It is. Small percentage, but significant enough that we can't afford to be careless.
So what can make that risk even higher after a needle stick injury?
A few things. The amount of blood. Larger volume means a higher chance of transmission. And then the depth of the puncture. Deeper it is, the worse it is.
Makes sense.
If there's visible blood on the needle, that's a red flag too. Probably a higher viral load.
Okay.
And the type of procedure matters. Anything involving blood vessels, ABGs, central lines, those are riskier.
And what about the patient themselves? Does their health play a role?
Absolutely. Patients who have high viral loads, low CD4 counts, advanced AIDS, they're much more likely to transmit the virus. That's why we have to be aware of the patient's overall health before we even go into surgery.
So, given all of this, what are the absolute must-dos when we're operating on a patient who's HIV positive?
Universal precautions. That's the golden rule. Treat every patient like they could be infectious. Doesn't matter if you know their HIV status or not. It's about protecting ourselves in every single case.
Which means...
Right gear, every time.
So break it down for us. What kind of gear are we talking about?
Full face mask, or at least protective glasses. Crucial, especially when we're using power tools. Lots of splashing.
And gowns.
Waterproof, disposable gowns and drapes. Especially important when the viral load is high, like during seroconversion.
Sure.
Closed-toe surgical boots, no clogs. You drop a sharp, you want your feet protected.
Gloves.
Double glove, extra layer of protection never hurts. And go a size up for that inner glove. Keeps you comfortable during those long procedures.
Smart. What about like who's allowed in the OR and how much we're moving around.
Keep it to essential personnel only. And everyone needs to be mindful of their movements. Less movement, less chance of accidental exposure. Handle them with extreme care. Always use a kidney dish. Dispose of them properly. And your surgical technique, it's got to be meticulous. The less bleeding, the lower the risk.
So let's say even with all these precautions, we have a potential exposure. What then?
That's when post-exposure prophylaxis comes in, PEP. It's our safety net. It can actually prevent HIV infection after a possible exposure.
Okay. So walk us through it. What do we do immediately after a potential exposure?
First thing, wash the area. Soap and water. No harsh scrubbing. If it's a puncture, let it bleed a bit. Help flush things out. Mucous membranes, including the eyes. Rinse them with water. Thoroughly.
Okay, what then?
Risk assessment. STAT. Someone other than the person who was exposed needs to do it.
Makes sense.
You have to look at the type of exposure, the fluids involved, how it happened, how bad it was. All that goes into deciding what to do next.
So PP isn't automatic.
No, not always. If it's low-risk stuff, urine, vomit, things like that, usually PEP isn't offered, unless there's visible blood.
What about the person who was exposed? What role do they play in all this?
Their views matter. They have the right to know what's going on and be part of the decision about PE. It's their health on the line.
And if PEP is recommended, what medications are we talking about?
The starter decks usually have a mix of antiretroviral meds. The goal is to stop the virus from replicating.
And which meds are those?
You're usually looking at zidovudine, lemivudine, and nelfinavir. They're the heavy hitters when it comes to preventing HIV after an exposure.
Okay. Well, this has been quite a crash course.
It has.
We've covered a lot of ground when it comes to HIV in the surgical setting, from the risk factors and how it spreads to all the precautions we need to take and what to do if something happens.
Important stuff to know, especially for those exams coming up.
And it's, it can't be stressed enough. We have to keep learning. Things change. Guidelines change. We have to stay on top of it.
Absolutely. And for everyone prepping for those surgical exams, this is a topic you really want to dive deep into. The better you understand the ins and outs of HIV and surgery, the better you'll be at keeping your patients safe. And yourselves.
So let's get practical here. Let's talk about what to do if there's a potential exposure to HIV in the OR. What are those immediate steps?
Action. Fast action. That's the key with PEP. The sooner you get on it, the better your chances of stopping that infection.
So how soon are we talking?
Ideally, within 72 hours of the exposure. But honestly, the faster the better. Doesn't matter if it's been an hour or two. Get medical attention. Get that PEP started. Time is really of the essence here.
Okay, so let's say we start PP. How long does that treatment last?
Usually it's 28 days of antiretroviral meds. But it's not, one size fits all. The exact regimen, how long you're on it, it can change depending on the situation, the individual.
So we need to...
Individualize, yep. You need a good risk assessment. Talk to an infectious disease specialist. They'll help figure out the best course of action.
Now let's talk about something that doesn't get talked about enough, the mental side of things. What happens to a healthcare worker after a potential HIV exposure? I mean, that's got to be stressful.
Hugely stressful. You're talking about a lot of anxiety, fear. It can be overwhelming. And that's why counseling is so important. Support services. Anyone who goes through this needs that kind of help.
So what can hospitals do? How can they help their staff through something like this?
Protocols. Clear protocols. How to manage potential exposures. Make sure there's quick access to risk assessment, PEP, and counseling. All of it. And maybe even more importantly, the hospital needs to create an environment where people feel safe talking about this, being open, supporting each other.
Sounds like we need to be taking care of the whole person, the physical and the mental.
Absolutely. You can't take care of your patients if you're not taking care of yourself. Remember that.
Well, I think we've covered a lot here today.
We have.
This deep dive has really given us a comprehensive look at HIV in the surgical setting.
Yeah.
We talked about everything from the virus itself to how it spreads to the precautions, what to do if there's an exposure, even how to manage it emotionally.
A lot of ground covered. And all of it crucial for surgeons, especially those getting ready for those exams.
So as we move forward, just remember, continuous learning is key. Those guidelines are always changing, so you got to keep up.
Stay curious. Keep learning. Dive deep into this topic. The more you know, the better prepared you'll be.
All right, so we've covered a ton of information in this deep dive, really focused on those key facts about HIV in the surgical setting. Especially for you residents out there getting ready for exams, let's just hit those main takeaways one more time, just to make sure it sticks.
Sounds good.
So, first and foremost, Universal precautions.
I can't emphasize that enough. It's not optional. Every single surgical procedure, every patient, doesn't matter what you know or suspect about their HIV status, you treat everyone the same.
Which means
The right PPE. Every time. Gloves, masks, eye protection, gowns, the whole 9 yards.
and of course, we can't forget about surgical technique.
Absolutely. If you're operating on a patient with HIV, meticulous technique is critical. Minimize that blood loss. Keep the tissue trauma down. That's how you reduce your risk.
Makes sense.
Mhm.
And we talked about what to do if there's a potential exposure,
Right. Action. Fast action. That's what PAP is all about.
post-exposure prophylaxis.
Yep. And the sooner you start it, the better. Those first 72 hours are key.
So what does PEP actually involve?
You're looking at antiretroviral meds, a combination of them, usually for 28 days. But the exact regimen can change, so you definitely want to talk to an infectious disease specialist. They'll know what's best for each situation.
And, it's not just about the physical side of things. We have to remember the emotional impact, too. Those potential exposures, they can really take a toll on healthcare workers.
No doubt. It's stressful,
Yeah.
scary, and that's why support is so crucial. Counseling, open communication at work, that supportive environment can make all the difference.
Absolutely. Well, I think we've given everyone a solid foundation here.
A good starting point.
You've got the basics on HIV in the surgical setting. Remember, this is just the beginning. You got to keep learning, keep up with those guidelines. That's how you stay sharp. And for everyone facing those exams, best of luck. You got this.